Hi, this is Dr. Subhakar Nadella, Clinical and Interventional Pulmonologist, Department of Pulmonary Medicine, KIMS Hospitals, Kondapur Division. This is an interesting case of 78 years old male who was referred to us with the complaints of loss of appetite, not able to get up from the bed from the past 5 months. He was debilitated, he could not eat properly, and he had continuous history of fever on and off, for which various antibiotics were given. The patient was evaluated thoroughly where CT scan was done previously. In the CT, we could see that on the right side there was some fluid-filled lesion which was not communicating with the right main bronchus, and there was complete cutoff of right intermediate bronchus with a bit of luminal filling defects. Bronchoscopy was attempted twice but differed in view of bleeding on touch. Bronchial washings were negative, gene expert was negative. Sputum for cytology, 3 samples came out to be negative. Pleural effusion was seen on the right side, which was tapped, which was again exudative, neutrophil predominant and low ADA. So, patient was finally referred for a surgeon to go for lobectomy to know what exactly was happening as well as therapeutic purpose. Before going to the surgeon, the patient had a PET CT scan done. PET CT scan showed there were mediastinal lymph nodes with SUV uptake of around 2.7, and the right intermediate bronchus where the luminal filling defects was seen, the uptake was 8.9 SUV, and there was some fluid filled lesion in the right lung in the lower GM parenchyma where the uptake was around 9. There was no communication of that with the endobronchial tree. So the patient had comorbidities of hypertension, diabetes, coronary artery disease, atrial fibrillation with fast ventricular rhythm, which was controlled now, and hence the surgeon denied to go ahead. He was referred to us with this condition. We initially planned for a bronchoscopy. In the bronchoscopy, when we went in, we could just see there was a complete cutoff from the right intermediate bronchus, but it was not like extrinsic obstruction. So we carefully wedged the scope. We went ahead and took biopsies from the right intermediate bronchus. When we were sure there was no further bleeding, we wedged the scope and gave water flush. Wherever we could see the jet where it can move, we carefully took tissues from there, bit by bit. When we went ahead, after removing few centimeters of the tissue, we could directly go into the cavity where suddenly 700 ml of pus was drained. So after draining, we could directly see there was a cavity inside. So even from there, biopsy was taken. So finally, after finishing the procedure, we came out. We could see that the cavity which was seen in the PET, it was in connection with the right middle lobe, lateral segment. The pus was drained and samples were sent for analysis. Here, from the pus, Pseudomonas growth was seen, and unfortunately, the biopsy samples sent showed non-small cell lung cancer.